Hello, and welcome to the second event in the Meadows Mental Health Policy Institute speaker series, where we're taking a deeper dive into implementation science and all the things that support the successful implementation of evidence-based mental health programs and practices. I am Tegan Henke, Senior Director of Program Implementation for the Child and Family Policy Team. And at the Meadows Institute, our goal is to help Texas to be the national leader in treating all people with mental health needs. And this speaker series is one of the ways we're doing that. We aim to provide data-driven, nonpartisan, and trusted program guidance and support to elevate all the great work many of you are doing in communities across Texas. Our first webinar featured Dr. Melissa Van Dyke, who gave us a great foundation in understanding just how complex implementation can be and what research tells us is most likely to help your program succeed. If you missed that webinar, not to worry. You can still catch it on our events page of our website. During that webinar, Dr. Van Dyke discussed the importance of using data to make implementation decisions. And in today's webinar, we'll build on that by taking a closer look at what we mean by data and how you can more effectively use it. And I know I'm excited to learn more about this topic. Before we start, I have a couple housekeeping notes. Today's session is in webinar format and all participants will be muted. The session will be recorded and posted on our website within a few days. If you have any audio or tech issues, please use the chat box and a member from our team will help provide support. And now on to the main event. For today's webinar, I am thrilled to welcome Dr. Jennifer Gonzalez. She is the Senior Director of Population Health at the Meadows Institute and leads our research and data portfolio. She holds an adjunct associate professor appointment at the UT Health School of Public Health, and she earned her doctoral degree in epidemiology from the University of Florida. She has maintained a portfolio of more than $10 million in research funding over the past decade and has published more than 100 peer-reviewed manuscripts focused on the health of those who come into contact with and work within the criminal justice system. We're so excited to have you, Dr. Gonzalez.
I'm happy to be here. Thank you, Tegan.
Yes, and we have a very special treat today. You can begin to share your screen too, Jennifer. We have a very special treat today because we also have Dr. Patrick Tennant joining us, and he will serve as our resident clinician during this presentation. Dr. Tennant is a licensed marriage and family therapist and brings over a decade of experience working in the mental health field as a researcher, evaluator, and clinician. So we're really hitting all the things today. We're talking about data and the clinical application of that data. And Jennifer, you might want to put your presentation in presentation mode. There's a lot of presentations there. Technology. All right, so I am ready to dive right in, but before you start, I want to let our audience know that Dr. Gonzalez will be taking questions and Dr. Tennant will be joining at a couple different points for discussion and to answer questions. So audience members, please submit your questions using the chat or Q&A functions. And with that, Dr. Gonzalez, the webinar is all yours.
Wonderful. Thank you, Tegan. And thank you, Dr. Tennant, for joining me. I'm very excited to talk with you all today about how to use data for your organizations and to identify questions that need to be answered and to get started in figuring out how to answer those questions to improve patient care, but also to improve your programming and informed decision-making as well. So I'm Jennifer Gonzalez. I've been with the Meadows Institute for about 1.5 years now, and I have managed all of the data work for the Institute. So Patrick Tennant is one of my team members who recently joined us from Rice University, and he has been very active in working with clinical partners and with our children's portfolio of research at the Institute. And so he'll chime in periodically to kind of bring a clinical lens to all of this data information that I'll share with you today. So just to give you an overview of the things that we're going to talk about today, so you're oriented and ready to learn, we'll start really simple, describe what data are, because quite frankly, it's everything is data. And I think it's a little bit, data seems like a scary thing that you have to have access to and sophisticated skills to manage, but it doesn't always have to be that way. And it's likely that you have data at your fingertips that you're not even recognizing yet. So I just want to go through what data are and define this. So we're all working with a baseline set of knowledge here. And we'll talk about how data can be used in clinical settings for behavioral health care specifically. We'll talk about ways that we can use data to assess our patients' clinical needs, recognize the needs for organizational adaptation, or if there's a problem that's happening in your clinic, if we can detect that using data maybe a little bit sooner than we would be if we weren't monitoring our data periodically. And we can also use data to evaluate whether programs are effective in changing participants' behavior. So that may be the ultimate goal, but we want to make sure we have everything set in place so that before we start that evaluation process, so that we can more rapidly begin the evaluation rather than getting the infrastructure in place to even start an evaluation process. So it's really important just to have that infrastructure for data set up. And like I said, it's not a massive software situation where people need to be trained. It can be a very simple and manageable endeavor for your organization. And finally, the broader overarching goal of today's webinar is to discuss the ways in which data can be used to guide your decision-making and organizational decision-making. So some of that, we'll start with a review of what data look like, what kind of data you might have available, and how that can be used. So this was a quote from 2011 from back in the day, that information is the oil of the 21st century and analytics is the combustion engine. So this man is the head of research for a large IT firm globally, and it's a little bit over exaggerating the need for data in the way that a tech company might be trying to sell you a product. But it seems important to highlight the importance of data, and likely that the importance of data will not dissipate in the next 50 years or so. That question of the need to answer the why question is unlikely to go away. So it's really important that we at least begin to track our metrics in behavioral health organizations, and really all healthcare providers, to better be able to articulate the need for additional funding, for additional resources, whatever you might need, assuming that there are some gaps in care and the organizations are not operating perfectly, so that we can leverage all of those resources that we need to function and operate evidence-based practices as they should be. So let's start with a quick survey. So I like surveys, I'm a researcher. So let's start with just a couple of questions so I can assess your baseline knowledge of data related things, to be specific. So the first question, do you have data at your organization? We should have had an I don't know option, but I suppose if you don't know, we'll just select no. Have you collected data? Have you analyzed data? And have you used data? So using data as in written it down, thought about it. All of that is use of data. Tegan, could you let me know when everybody's finished?
Yeah, so far we have about half of people have responded so far. So maybe we can leave it open for a few more seconds.
Okay. They might be thinking about their answers.
Yes. All right, I just got word. I think we're close enough.
Great. Oh, wow. Okay, so I'm impressed with this. And everybody can see these results? Tegan?
Yes, I believe everybody should be able to see them.
Wonderful. Okay, so almost everybody has data at their organization. You've all collected data, and most of you, so 87% have analyzed data, 97% have used data. I'm floored by this. It's a much more sophisticated audience than I was anticipating. This is great. Okay, well, let's move on. I was expecting to see a lot of change at the post-test assessment, but perhaps we won't see as much as I was anticipating. That's okay. So let's move on and talk about what we need data for. And since you all are pretty familiar with data, this might be old news to you, but but that's okay. So we need data to answer a question that's clinically important, right? Important for knowledge, important for how the clinician operates, important for how the patient care proceeds. So it's not enough to just have data to answer a question that's not. Some researchers in particular, some folks will say, well, this never been studied before, or we've never looked into this before. Well, that doesn't mean it's going to be important. It's not going to drive a decision. It's not going to inform policy or practice. It's just good to know. And unless you're doing that because it's important for a future program, perhaps, or a new direction that you're looking into for marketing purposes, may or may not fall under the important question umbrella. You can also use data to generate those important questions. So you may have like a thought. I come across this is how I generate some of my best ideas. I think something is going on with young women in substance use treatment. They're dropping out at high rates. And so I go to my data and I look and I see high rates of alcohol use disorder in those groups of subgroups. And so that led us to have some specialty programming and additional resources available for women with alcohol use disorder. So it can help you get at that answer of like, what is happening with this population that I'm seeing these trends in my data. So some important questions, some characteristics of them are that they're aligned with the organization's mission. And this is really important so that when you build an infrastructure for managing your data, again, not a complicated infrastructure, that's a complicated word, but it is when you're building a way to look at and manage data, you don't want the questions that you're looking at to be transient. You don't want to look at something that's important to the boss today, but may not be a year from now. You want to look at things like changes in PHQ-9 or CAN scores, perhaps, at between 2 visits. You want to see that they decline over time, perhaps. I'm thinking of depression screens. You want to see that with more sessions. On average, people do better. So that's the kind of infrastructure you want to set up, things that will not change, and not just kind of the flavor of the week type of metrics. They also inform clinical practice. So like the changes in depression, you might want to monitor things that'll be clinically important that you could pull. So I was envisioning a dashboard where you could see your entire clinical load by, say, provider and characteristics of them. And then you could zero in down on one particular patient to see how he or she is doing and take a look at their progress. And that could inform what you need to do moving forward with that patient. You could also, an important question really gets at a gap in services or an infrastructure. So if you're not serving a population well, appropriately, or perhaps intensely enough, or if one group of people consistently are not getting better, that'll give you an idea of future directions with that subgroup of folks. It can also provide the basis for a grant application, which I think is especially important now, given the influx of funds that I think we're expecting to see federally. And so if you have data on what the needs are and what the gap in service is, then it's very straightforward for you to articulate that need to a reviewer. And it can also serve as the basis for policy change. So that's how our institute works, is we take data and we translate it at the population level and say, look, this is how many people aren't getting care, or this is how many people need care but aren't getting it. And so it's very simple metrics that have a tremendous impact when they're scaled to the population level. So now let's start with, what is data? So let's start off with the very simple. So data may be something very simple, like statistics that you pull out of a report from, say, that was put out by the Centers for Disease Control and Prevention, or perhaps one of our reports. You might cite the number of people who completed suicide in 2018 in Texas from one of our reports, from one of the CDC's reports. So that's a statistic, and you're not getting it from the original source. The original source could be the death certificates which are aggregated in CDC's Wonder website or database, and then interpreted by somebody and placed into a report by somebody else. Okay, so you're pretty far removed from the individual data at that point. But data can also be almost anything. So it can be text, free text, like clinical notes, and that's what we call qualitative data. It can be yes or no, like Hertz scales. Numbers is what we traditionally think of data. And an example of a Likert scale, just in case you're not familiar with that word, is to the right here in this diagram. So if we rated the level of agreement with each statement, that chocolate ice cream is delicious, I'm not sure that anybody would check strongly agree, but if I had to answer this, I would answer strongly agree, because who thinks that chocolate ice cream is not delicious? I know there's that one person in the webinar that would check strongly disagree. So this is an example of a Likert scale, and we actually translate this into numbers. So when you receive a data set, an actual data, a raw data set, it's just a series of numbers that don't make a whole lot of sense to an untrained person, but it doesn't have strongly disagree, strongly agree in there at all. And so there's several different elements that need to be incorporated when you're working with raw data, such as a data dictionary and code books and such. But this is where it starts. This is how the user interacts with or produces the data. There's also more creative things that can be used as data as well, like pictures. People can code elements of pictures. People can code elements of how somebody speaks. The field of linguistics just codes people and the way that they say certain words, which is pretty exciting. I think that posts on social media, everything you've ever typed into Google, all of that, I looked at my Google Analytics dashboard today, and I was a little surprised at what I saw, but everything is tracked and can be downloaded into a single database, in which every row in that database is an interaction that you had with Google, either Gmail or you Googled something, and it's all recorded there. Posts on social media is all recorded, and people are actually doing research in which they pull information from Twitter or Facebook, and they can purchase information from those sites as well. And then GPS coordinates, almost anything that you can think of is data, and is collected and can be monitored by somebody that is needing to use it. So if we think about this, and if we depict this in a chart, the most simple, straightforward, comprehensible, the easiest way to get some data is to go take a look at our charts. So the CDC's charts are the National Survey on Drug Use and Health puts together some reports that are very consumable and easy to use. But at the same time, those are really limited because you don't know anything about their measures. So for example, I like to use depression. So if you're going to report the rates of depression using some secondary source like the CDC or our information that we publish at the Institute, are we talking about diagnoses? Are we talking about screening? Somebody screened positive, they likely have depression. We don't know if they actually do. Some of those tests are not as specific, or they're not as accurate as we would like. And then are we talking about somebody used a diagnostic measure, but they weren't actually evaluated by a clinician? So there's just a lot of questions here around the measurement itself, and then around the age group. So the age group, meaning, is this children between the ages of 12 and 17? That's what we commonly use at the Institute. Is it people under 18? And the age group can be really important, right, when you're dealing with children, since treatment likely varies at every developmental milestone. Then we're talking, then the next step that's a little bit closer to the raw data itself is the aggregated data. So I'll show you some examples of that. But this is when we take the raw data and generate, say, a percentage out of it. So there are some really nice resources out there. You can interact with the CDC Wonder app. It's very user-friendly, and there's a guided user interface with it if you want to know, if you want to work directly with the data without downloading the data itself. So that's a little bit more complicated to do, but at the same time, you know what metrics you're working with. You know what the measures are, you know what the age group is that you select, you know all the specifications that go along with the measures that you're reporting, with the information you're reporting. And then finally, the raw data, if you work directly with the raw data and generate percentages from it, it takes a much longer time. It's more complex usually, depending on the data you're working with. But at the same time, you have control over every assumption that you're making in that data set. So some people have missing information, like they wouldn't have, if it was a depression screener they were completing, might have skipped the last 2 questions. So do you leave in those people? Do you remove them? Do you assume something that they completed the last 2 questions based on their scores, the average of their scores in the last 2 on the first 7 items perhaps? So there's a lot of different ways to manage this. And I think everybody who analyzes the raw data might do it a little bit differently. And so you'll know exactly what you did. And for this reason, I think a lot of statistics are really hard to replicate by somebody else. So some common data sources that you all might use as clinicians are largely primary data sets, and they don't necessarily have to be surveys. They could be administrative data sets, which are largely secondary, which only means that they are used for another primary purpose, like electronic health records. So skipping to the bottom here, an administrative databases like referral lists or patient addresses. And it might be really helpful to map out where were our patients coming from in terms of where they referred from, what providers are our best sources of patients, and then where do these people actually live? Like, is it easy or hard for certain people to get to our clinics? And so you might notice that when you map them, their addresses, you see that there's a train or a bus line, like the location of our patients clearly follows a train or a bus line. So it can really tell you a lot about access to care and how certain people may find it challenging to get to your location, depending on where they are and what kind of transportation they have access to. So that's just an example, but some primary data sources that you might administer are things like surveys, like satisfaction surveys are fairly common and can be used directly to improve clinical care. Interviews with some focus interviews or focus groups. So an interview is just one-on-one or a small group interview with clinicians or with patients directly to try to inform, to try to improve the process, either through scheduling, interacting with the administrative staff, barriers in getting care. All of those things can be assessed qualitatively with interviews, meaning it's non-structured. It's, what do you think about your relationship with your provider? And so you end up getting a lot of text, and you can go through that and identify themes that are commonly brought up by participants. So this is often very helpful for clinicians. So Patrick, can you think of any other examples of primary data that are routinely collected in behavioral healthcare clinics?
Thanks, Jen. And yeah, I think there are some good examples we could use. I believe the CANS, the Child and Adolescent Needs and Strengths questionnaire, is one that's commonly used among our attendees, and that's a great example of a self-report of symptoms. Again, not the same as a clinical diagnosis exactly, but can get you in the direction of understanding for an individual patient or for the entire patient population that you're serving, what are the the needs and the strengths or the areas in which intervention is needed. So that would be another example of primary data. And secondary data, exactly like you said, electronic health records or your administrative data can be really, really helpful for clinical organizations in terms of planning the services they're going to provide short and long term. Strategic planning, you need to think well in advance of what your patient population might need. And so observing those trends over time could be really, really useful in that way. And so I think you gave some good examples. I think our participants probably have some more examples as well. But I just really want to highlight the importance of the purposeful use of data that you were talking about earlier, focusing on the important questions and how you can make sure that the data you're collecting is is going to be useful and valuable, because the reality is that it can be burdensome for participants to provide that information. It can be time consuming and resource consuming to collect and manage and analyze and report on that information. So really focusing on the importance question that you brought up earlier, I think is always a good idea too.
Thank you for that, Patrick. And it looks like we have a question that I'd like to respond to right now, if we can, because I think it fits here. The question is, how do you know if your data source is reliable? So in terms of, I have more questions about the question, but the question for me, the answer to the question for me is there are multiple ways to get at whether or not it's reliable. So the first question, if this is a survey and you're asking questions that are not going to inform clinical care directly, but they're, say, the satisfaction survey. You could pull this from a source that is well established in the field. Satisfaction surveys that have been used in public, this is a really good indicator of whether or not somebody is going to be happy with and continue in their care at your clinic. That's one way to do it. Another way is to ask the same question multiple times. So if it's something that patients report, like when you go to the dentist's office, you fill in a series of questionnaires that's yes, no, like I've had heart disease in my family. You just ask the same question at each visit, and you can see if perhaps it was an error that somebody checked, yes, I have heart disease. And so that may not be as reliable if they checked heart disease just one time out of their last 4 visits. So those are 2 ways I could think of getting at whether the data source is reliable. Do you have any other ideas, Patrick?
I'll just add one, because I totally agree with your suggestions there. And using well-validated, clinically researched tools is certainly best practices for things like screening or assessment tools. On something like a satisfaction survey or something that's a little bit more casual, I would really tend towards what researchers will call face validity, which is just, does this question make sense on its face? Can you understand exactly what it's getting at, and can your participants understand exactly what it's getting at with no hidden meaning or no secret calculation going on, behind the scenes? We want really face valid questions that are going to be clear to everybody, because that'll make your interpretation a lot more straightforward. And if you need to use that information to convince someone, say a funder, of the value of the services you're providing, then it makes it a lot more straightforward and a lot easier to make that case using really face valid items. So that's what I would encourage.
Wonderful. Thank you, Patrick. All right, so there's a couple of ways to ask these questions on this satisfaction survey, depending on what you're looking to get out of it. If you're just starting a new program and you'd like to get some open-ended feedback, then this kind of structured question, think of the chocolate ice cream chart that I showed you a couple of slides back. That's it. How much do you agree or disagree with each statement? Well, you could ask a similar question to assess how happy somebody is with the care that they received. You could force people to say that they strongly agree or are very satisfied or very unsatisfied with their care. And that's one way to easily quantify. You could say 80% of people are satisfied or very satisfied with their care. And that is a really good measure of how people who come to your clinic are satisfied or not with their care. But if you're administering a new program, you might want to know how you can improve the services that you offer. And so we might want to get people could write almost anything to this question. This could give you a broad range. We don't like the clinician, we don't like the location, we don't think this is a good use of time. You could get any range of feedback. So when you're putting together the satisfaction survey, if you may not find something out there that is already being used. So by researchers or other people who are measuring satisfaction. And so you might put together your own survey that includes a variety of these different measures, depending on what you're trying to get at. Because the second question won't be useful. How can we improve the services we provide if you're looking to find out how satisfied people are with their care? So those are just 2 different ways to structure an assessment. And it's also really important to be careful to ensure that any surveys are culturally competent. So in other words, think about your patients and whether or not they can read and write. So when I put together forms or anything that's informational for people that I work with, and even though they're adults, generally, I try to keep everything at a 6th grade reading level. So very, very, very simple, just so that everybody can understand what I'm trying to say. And especially if your patient population does not speak English or largely does not, you may want to make accommodations such that there's a satisfaction survey in Spanish and there's one in English. And perhaps there's somebody available who can write somebody's answers down for them if they are unable to write or for whatever reason, not literate at the 6th grade level, and someone may need to translate that even further for them. So you want to make sure that everybody's equally able to participate so you get good representative feedback on your survey. So now let's talk about just data sources and what this data. So I've used the word data set in the past, and this is just a collection of data for a specific purpose. So that's a pretty general definition. But for the purposes of this discussion, this data set here is 500 records. That includes age. You can see column B here is the age of each patient, and in column A, you'll see an ID number, and each of those ID numbers represents a single patient. So every patient has their own row here. So if I were to export my Google dashboard, every time that I interacted with Gmail or Google Chrome or any other Google product is its own row. It's its own interaction. So this is every time a patient came to our facility, to our clinic, they're inputted here, perhaps with their address and phone number, their contact information. You could see column C is their gender, their blood type, weight. So this is a numeric measure here, and all of this is inputted by an administrative staff member. Okay, so this is what the data on the back end end up looking like. It may look like a nice form on SurveyMonkey or an Access dashboard when it's being inputted, but the back end, whenever you click on that export data button, that I think a lot of people are afraid to click on, it'll look something like this. Do we have any other questions so far? I'll give you all a few minutes to kind of think, and then we'll move on to different types of data. All right, well, if there are no new questions, we will talk about different types of data. So if you think about that pyramid I showed you a few slides back, I showed you that the top of the pyramid, the farther displaced from the data that you become, is information from charts and graphs. And so this is an example of a chart or a graph, and there's a lot of questions that come from it. And so I'll walk you through some of those now. This is the number of the percentage of high school students who seriously considered attempting suicide during the past year in the United States from the Youth Risk Behavior Survey over a 10-year period. So this is essentially just charting the percentages over time to see if they've increased or decreased. There's a lot of questions here. So the first question for me is, well, what are the age ranges we're talking about here? Oh, I'm sorry. Oh, I'm sorry, guys. Let me reshare. I hit something I should have, and so that was, oh. All right. Okay, so the age range. So we're talking about high school students here. What does that mean to these folks? There's going to be people who didn't answer this question, people who weren't asked it at all. How is that information recorded here? The next, on the right side, you'll see a breakdown across males and females, and you can see the rates are very different. And although they do tend to increase, they increase much more for females compared to males. But what about people who don't identify as a certain gender, as one of these gender groups or sex groups? there's a growing number of high school students, sometimes up to 5% in some samples, that are identifying as a third identity. So they may skip this question if there's no other option available besides male or female. So if you had the raw data yourself, you may be able to deal with those individuals a little bit differently. And it's very likely that those people were excluded from this male, female, and probably even the total trend line on the left, because there was no category of other sex that was available in the 2009 survey. So it's likely that these people, the people who created these figures, they didn't want to compare apples to oranges and insert a new group starting in, say, 2017. So it's important to have consistency over time in your measures. And so we're just inferring what these people who created these reports decided to do with their data. But it does highlight the importance of like understanding the data and looking at it yourself so that you understand the decisions that were made. The next step down on our chart was aggregated data. And so this represents things like counts, percentages, number of votes, as in the a number of votes for, say, Donald Trump in a given district, the number of patients who were served by a given clinic, or the percentage of patients that were served who received medication-assisted treatment. So you have your raw data up here on the top, but the aggregated data, so what you're most likely to use is down here at the bottom in the red box. And so you can see the total sales for a given period are over $8,000. And what that is just a sum of column C in the raw data above. But this is an example of how you could take the raw data and turn it into something very useful very easily. And so now you understand what total sales is. You could take it and turn it into a report and fully understand what you are reporting. All of these are just Excel algorithms, very easy formulas that can be plugged in and completed by almost anybody. You can get the total number of unduplicated customers, total number of orders. So in the case of behavioral healthcare clinic, this could be the total number of patients, the total number of times the patients were seen. So let's say we had 8 patients and only 10 visits over a 2-month period, that may not be a sign that our patients are coming in repeatedly. So they're not coming in for follow-up visits as often as they should. Okay, so just a really easy way to monitor your raw data without counting manually. So then we look at the raw data itself, and this is where every interaction that I had with Google has its own line. So in this case, every patient has its own line. The patient's name, you could have, instead of sales, it could be diagnosis 1, transaction ID could be diagnosis 2. You could have 30 different diagnoses there if you wanted to in this spreadsheet. Any type of treatment they received, so it could be 3 columns dedicated to different types of treatment, a date of entry for treatment and a date of discharge. And you could very simply create this total number of patients. And then you could have total number of patients with a disorder, a particular disorder. That's a little bit harder to program in Excel when you get to 2 different columns. So you might want to use a statistical software package for that. But there are some that have guided user interfaces and are manageable, I think, for people who have some level of statistical knowledge. So I think that you all, given your baseline level of competency, would be in a good place to start at that level. So here's a nice quote that I think highlights the importance of the current place that we are in life and the importance for data, of using data right now. So here is, we believe now is the time to double down on planning, goal setting, data collection, measurement, reflection, and continuously adapting strategies as we learn. Used properly, these tools provide organizations a structure in which they can learn in the moment, shift course quickly in changing circumstances, and ultimately create more impact both now and well into the future. And given the potential impact of COVID-19 and if there is an impact on funding for behavioral health or not, it'll be really important to show that your organization is using data and becoming adaptable, and so that you're in a good place to get those resources if in the event that they become scarce. You want to be in the place to say, well, we shouldn't be losing resources because look at all the good things we've done. And you can't be in that place with just anecdotes, with just quotes from patients who really got better from your care. You want to have some statistics to support that. So to get back at that important question, I keep circling back to that because it is really important. And let's talk about what you need to be able to get at those important questions. So the green box, I call it the onion on the left, shows us the 4 different types of data analytics. And the first level, which is the smallest circle, is descriptive. And so that's described in the green box on the right. And that's just telling you what is our data telling us? Like what is happening in my clinic? This says in my business, but this is a very, very relatively easy question to get at. If you think about that sales figure we just looked at, that's just the average sales or the total sales. Okay, so how many patients am I seeing? What's the breakdown of patients by therapist? What is the total? What's my revenue that I'm generating? These are very simple things that you can assess, that you could perhaps even self-teach yourself to do very in a non-statistical format like Microsoft Excel. And this is most of the time what you need. You need to know how many people are getting better. If we're collecting CANS data, what percentage of youth improve over time that are in our program? Same with any depression measure, any information that you collect. How many people are discharged from treatment for a good reason? So, and that's much better than the rate of people who are discharged for a bad reason. So I would say 90% of the data that maybe even more than that, we use at the Institute to when we work with clinicians, to tell them how to improve their practice. It's this descriptive data, right? So this is really critical, really important, and mostly what you need. Then we get at why is it happening? So I would say the other 90%, the other 9%, and then there's the 1% is the red. So why is it happening would be 9% of the work we do here at the Institute. Let's be able to get at the root cause of the why. So what's happening in my business? Then I know why is this happening? So if we know that if people are just not coming in for follow-up visits, well, why is that happening? Perhaps we go to the satisfaction survey, and we look at all the text responses and lump them into themes to help understand why this is happening. Or we could do it quantitatively, and we could say people are not getting better, and those people who are not getting better are much more likely to not come for a repeat appointment. And we could use statistical tools to do that. So that why is really important to help us figure out how to fix a problem. But there's you could just figure out the problem and come up with a number of reasons, a number of ways that you could fix it without going to step 2. And it's yellow because it's a bit more complicated to get at this. There's a few more steps involved, and it could be a little bit more challenging analytically. And the third step is the predictive and prescriptive analytics, and those are projecting into the future, which is the remaining 1% of the work that we do here at the Institute. So what's likely to happen in the future with COVID-19, and how does it impact rates of suicide and drug overdose deaths and major depression into the future? And it's really important to project capacity, right? So project need for services so that we can prepare ourselves. There's a lot of error here, and it's a very challenging thing to do. And with this, in the case of COVID, we were going in blind a little bit because this is not a situation that has really presented itself before. And so we relied on some of the work that's been done in the past, but much of it was not directly applicable to what is going to happen in the future. So our projections actually turned out to be fairly reasonable for some of the, which is it's unfortunate, but now that we're seeing the rates of death kind of increase for drug overdose deaths in particular, it's very challenging. It's very difficult. But anyway, so you might use this to project how many more clinicians you might need. And so this is a much, much more difficult thing to do. That would certainly require some help from another organization or consultant to think through. All right, and so how can I use my data to figure out what patients need? So have you measured a wide variety of patient needs? This is really important to think about. If you've only measured 1 or 2 measures for patient needs, then it looks like everybody needs the same thing. If you're only doing, say, a CANS assessment rather than an assessment for all kinds of different needs, then you might only narrow people into a few different, I call them buckets. And so everybody gets that same treatment, regardless of what, say, their trauma history is. Because I'm not familiar with the CANS, Patrick, I'll have to chime in for me and give me an example of how a clinical setting might measure needs more broadly than just, say, a CANS assessment. But the more measures of the same underlying phenomenon you can have, the better. So if I could administer a screening tool for depression when somebody's sitting in my waiting room, and then decide clinically whether they have depression or not, and record both of those measures, then I can get a much better sense of whether or not somebody has depression. So it's really important. And we want to measure all kinds of things, like a broad spectrum of risk, needs, histories, behaviors, all kinds of locations, demographics, everything you can think of, and without being overly burdensome to the patient, in order to be able to identify what the root cause is. So you'll have all these measures available. So when you say, like, what is it about a patient, type of patient that they're not coming to care? So then you have those underlying measures to look at. So in my example, when we had those women, we learned that they were mostly women with alcohol use disorder. They were mostly engaged in sex work or prostitution, and they had alcohol use disorder. Right. So we had all those underlying measures to be able to figure out what it was about those people that is putting them at risk. And so it's important to have measures, even if you think they're not relevant, and duplicate them. So you don't want to ask the same exact question twice, but a few different ways of getting at that underlying measure. Then are your measures high quality? So are they validated measures that have been used by other clinics and practices, and even better, from the scientific literature, which are fairly straightforward. You could find them on a quick Google search, but a validated measure is the best kind of measure if you're looking to measure something like a mental health condition, or whether or not somebody has it. And then how much data are missing? So if patients often skip assessments, or they skip a couple questions, then that's not really ideal. You don't want to have 20% of data on 20% of your patients and then assume that that represents your entire patient population. So your data are more useful when you have a broader representation of your patients in care. And how do we measure? It's the very last section here. How do we measure whether our program worked or not? So we have to define our key outcomes, especially what does worked mean? What does it mean that my program was effective? Does that mean that people came? Does it mean that people received care? Does it mean that they used substances less? Does it mean that they had fewer symptoms of clinical disorders that they had at intake? Does it mean that they dropped out of school less, or were involved in the justice system less, or whatever the more distal or the farther away out the outcome was? Does it mean they completed their course of treatment? What does worked mean? And then identify your best proxies for success. And so I am currently, we're evaluating the Dallas Deflection Center, which is a pretrial diversion center in the city of Dallas. And we had a lovely discussion. It was a very intense discussion over what engagement with services means. And so does it mean that you talk to a care manager? Does it mean you completed their assessments? Does it mean that you actually showed up to a service, or that you were referred to a service? And so we had a very intense discussion of what that endpoint, if somebody was engaged with services, does it mean they completed the services? So how far do you want to go in terms of, we call it operationalizing, but determining what's the cutoff point for my metrics? And how do I know if my program actually was effective or not? All right, so making a couple of things to consider on how to make data use easier. So have your organization, or think about how they can, if they're not already, tracking data more systematically. How can they start doing that? One simple way is just to, if you're using paper forms, to begin using something electronic. And it doesn't need to be something complicated. It could be simple, like Microsoft Excel, and just having more drop-down boxes so there's less error that can occur as a result of data entry. So there's also many software programs that are HIPAA compliant and designed for data collection and storage. Some of them are more user-friendly than others, and they output really nice graphics that you can use just to get a quick snapshot of your patient load. Look at differences by therapist, drill down the individual patient. They're not expensive, they're very nice. I don't want to mention specific products, but we could talk about that more later. And then think about how easy they are to use when you're trying them out, and how easy it is to visualize your data and just pull a simple statistic out of your data using each platform. And so a single place may not be sufficient to store all of your information. You might need to access some information differently or more regularly than others. But it must be easy to access and to use to inform care. So think about how you can innovate and collect data at the same time. So maybe it makes sense to create an app that'll help you see if maybe we could prompt people who aren't coming to care. Maybe we could call them, maybe we could text them, maybe we could somehow use this app to have them contact our care coordinators more often. That would be an example. We haven't seen you in a while. Click on this link to give us a call. And so it might just help with that simple reminder to contact care. Patrick, do you have any thoughts on other ways to make data use easier?
Thanks, Jen. I just want to add one piece on the software element of this, which is that there are a lot of softwares out there. Some of them are very good, others are less good. And without making specific recommendations on software, I would say you generally want to know how you want to use it and what you need it for before going shopping. Because some of them have lots of bells and whistles that'll strike you as very fancy and exciting. But if you have identified on the front end, like Jen said, what exactly it means worked, in your program, and what information you need to demonstrate that, you're a lot more likely to end up with something at the end of the day that is useful for your purposes specifically. So focus less on the bells and whistles and focus more on what exactly you need it for, which is a decision you can make before you start to consider which software, if any, is right for you. And again, as Jen said, sometimes the final answer might be that you don't actually need one of those, that you have everything in-house already that you need to keep a systematic and structured data set with all of the information that you need. So just keep that in mind.
Yes, thank you, Patrick. And that concludes our presentation for today. Just wanted to do a quick post-test survey to be able to see if there's any change, but we likely have ceiling effects going on here, which means you all have used data too much to have any improvement. I think so. I think so.
I thought that was like a hazard of your trade, Jen. There's never enough data.
I know.
That's great. Well, hey, we had one question that came in just in the last minute. We'll kind of wrap up here, but do you have any tips on how to use data to help with storytelling? I think that's a really important piece. There's being able to look at it, analyze the data, and then how do you tell a really good story using what you've got? Because there's so much great work happening, and we need to be able to share that in a way that resonates with the community so that they continue to support our work. Do you have any tips on making that leap in translation?
Yeah, my strategy is to start broad with my storytelling and say something really general about the problem. And then I narrow down to say something more general about the population. And then I said, this is the solution I think that I'd propose. And this is why I think that. So you could work statistics into all of those places. You could say this, suicide is, or COVID-19 is the third leading cause of death in the United States, and people with mental health conditions are X% more likely to have COVID-19 or die from COVID-19. And then you could say, we think the solution is better telehealth and treatment and in-home care for people who are at risk of both mental health and COVID-19 infection. So that's just an example, but I start really broad to get at the problem more generally and kind of catch everyone's eye and make them want to read more, if that is helpful. Patrick, do you have any ideas?
I'll just add very, very briefly, because I know we're on the time boundary here, but I think what Jen said is good general advice. I would even back up before that, and before you have analyzed or even gathered your data, I'd be thinking about the story that you want to tell. And this goes back to the importance of the question you're asking. But before you even have a data set, you can think about what is the story I want to tell, and you won't know specifically what the data you get is going to tell you, but you can know in general the sort of range of responses possible, and think about the story you want to tell there. So rather than letting your data drive the story, think about the story you need to get to, and how you can utilize data to make a compelling version of that, whatever the specifics of those responses give you.
I like this. It's kind of pulling together that clinical wisdom that you have, where you know your population, you've been working with them, so you know the story that you want to tell, and then helping find the data to support the story that you're telling.
Focus on the importance of your story. Yeah, exactly.
Yeah, that's great. Well, we are on a time limit, so looks like we had some changes in answers, so we got that all launched.
Wonderful. All right, everybody has data at their organization. I love it. Everyone's collected data. 95% of you've analyzed data, and 95% have used data. So that's wonderful. So the 5% of you that have not used or analyzed data, I hope you're thinking about how you might be able to start thinking about collecting and moving towards that data integration for your work. So thank you all for attending today. And Tegan?
Yeah, I'm gonna wrap this up, and just want to start by thanking the two of you for sharing both your knowledge and your practical practice wisdom with us today. So this is really great information. So thank you so much for taking the time to be here. And everybody who joined via webinar, thank you for joining us. We hope you continue to find this series engaging and applicable to your work. And we hope that you will stick with us throughout this year as we continue to explore topics around implementation science. And on that note, please mark your calendar for the next event on May 5th, when we will welcome back Dr. Patrick Tennant to help us understand how to choose an evidence-based practice that's right for your organization, especially now that you know about the data. We'll have another rich discussion around selecting evidence-based practices and important considerations around that. So thank you all very much for joining, and I hope you enjoy the rest of your day.